Hi everyone, welcome to our webcast titled Fit for Purpose, the evolving role of liver biopsies in MASH clinical trials and patient management post-drug approval. Before we begin, please note that the views and opinions expressed by the speakers during the discussions are their own and do not necessarily represent the official positions of the respective institutions or organizations. I will now hand the time over to Professor Nikolai to lead the discussion. Professor Nikolai, please.
Thank you, Yuzu. Greetings to all our listeners and thank you for joining this webcast. After a prolonged and rather challenging period of drug development for metabolic dysfunction-associated steatohepatitis, or as we know it, MASH, marked with numerous compounds failures, the FDA approval of Madrigal's thyroid hormone receptor beta agonist in March this year is a tremendous milestone. The approval ushered a new era for treatment of patients with the most common liver disease. Rezdiffra, which is the brand name, is the first drug that met both endpoints of MASH resolution and fibrosis improvement in the phase 3 trial. Before starting the conversation with our distinguished panel, I would like to pay tribute to Dr. Stephen Harrison, a remarkable colleague, a renowned expert in the entire spectrum of metabolic dysfunction-associated steatotic liver disease, and the main principal investigator in the resmetirom trials. Stephen was a driving force for developing new therapies for MASH, an outstanding collaborator and visionary leader in the field. The international liver community was deeply saddened by his sudden passing, and we are determined to follow his legacy for greater knowledge and understanding of MASH-associated conditions, as well as to develop effective therapies for MASH patients. As we honor Stephen's many accomplishments in hepatology, we also send our deepest sympathy and support to his family.
I too would like to, pay homage to Stephen, who was a dear friend, colleague, and collaborator, and really do miss him very dearly.
Those of us in Edinburgh who recently had the opportunity to work with Stephen are also very saddened by his passing.
I too will miss Steve Harrison. I didn't know him as well as I know some of the hepatologists in the community, but I worked with him on a number of projects, and he was always an engaging and very forthright colleague, and he will definitely be missed.
With the approval of Rezdiffra, which is now prescribed in the US, for the first time, an effective treatment option is available for MASH patients. The Rezdiffra label provides a wide latitude, as it is indicated for non-cirrhotic patients consistent with fibrosis stages F2 and F3, but without a specific requirement for a liver biopsy to determine patients' eligibility for Rezdiffra. This creates a new paradigm for the routine clinical practice as it differs from the requirement in clinical trials in drug development. Thus, the conversation in our webcast will focus on the role of liver biopsies in two settings. Firstly, treatment and clinical management of patients with MASH in real-world situation, and secondly, clinical trials for drug development of new molecular entities as novel therapies for MASH patients. I would like to start the conversation with a question to Dr. Sanyal. Hello, Arun. Can you please summarize the key points in the Rezdiffra label and how patients eligible for this treatment will be identified in your clinical practice?
So the label for resmetirom is intended for use in patients with MASH with fibrosis. And it really sort of indicates that there is a subpopulation who have started scarring down their liver, who are most likely to benefit from this drug and therefore worthy of being treated with this molecule. If you have very early stage disease, stage 0 to 1 fibrosis, those patients' background risk is much lower and it is not intended for that population. On the other hand, if you have progressed to cirrhosis, it is not intended for that population because the data are not out yet in these populations. So while we await those data, the current label is for people who have primarily what would be classically considered F2 and F3 fibrosis. Now, stage 2 and 3 fibrosis represent both the distribution and the amount of fibrosis within the liver biopsy, and this is defined histologically. Given the number of challenges about translating use of liver biopsies on a wide scale at a population level in routine day-to-day clinical practice for the whole country, there is a lot of interest in the use of non-invasive tests for this purpose. So my answer is twofold. One, that in some cases using NITs, the answer is pretty obvious, and primarily it will be, again, picking from the criteria for in the phase 3 program for resmetirom, patients who have a liver stiffness between 10 and 15 without any features of portal hypertension, and then of course also those who have an ELF score of 9 but less than 11.3, that may be another population. Now 10.5 for ELF has emerged as a potential cutoff for cirrhosis. Certainly anything above 10.5, we would look for other features of portal hypertension to make sure that we are not treating a cirrhotic patient. So in some ways, this is what we call a Goldilocks problem, where you cannot have too much or too little. It's got to be right in the middle. And so that's how sort of we're going to approach it. Having said all of this, sometimes you get discrepant data from NITs. The NIT world is not as clean as we like to think it is. And so sometimes, first of all, they are also not precision tools at this point. Number two, they are also sometimes give you different types of mixed messages. So I think there will be a subset of patients that, at least in our academic practice, we will continue to perform liver biopsies to get more clarity on making sure that the right patient is getting the right drug and not just throw the drug at everybody, because that would be irresponsible.
Thank you, Arun. We'll come back to the NITs a little bit later to clarify. But one other point to consider in the routine practice that will emerge is that some of the insurance companies, like the VA, may require liver biopsy in better defining patients that are eligible for Rezdiffra. I'd like to now turn to Dr. David Kleiner and ask the question. The results of the Rezdiffra phase 3 trial demonstrate a moderate effect size, efficacy that is approximately 25 to 30% of patients who met the endpoint. This means that a substantial proportion of patients have not improved or may have even progressed during the course of the treatment. What will be the role of the liver biopsy to assess treatment response in clinical practice, and, if necessary, to reassess the management plan, Dr. Kleiner?
Thank you for the question. With respect to the recently approved medication in Rezdiffra, there's not a whole lot of detailed information available yet on what exactly the histologic response looked like. We know generally the percentage that met certain endpoints. The primary endpoint was resolution of NASH, or MASH now, or reduction in fibrosis. And that's what we're talking about with this 25 to 30%. If you look at some of the supplementary data in the paper, though, on individual histologic characteristics, some improvement was seen in about 80% of patients for ballooning and inflammation and steatosis. So it does look like there's a substantial histologic response, but the actual magnitude of that change was not provided in the published manuscript. So I think there's a lot that we still need to understand about this drug, and what histologic response means and how durable it is. And that's all going to be in forthcoming papers and research, I'm sure. In terms of how one might use the liver biopsy, I'm assuming that that there will be some guidance as to how to monitor patients non-invasively after initiation of the drug. And then, if you don't get the results that you expected or something unusual happens during the course of treatment, then you might go to a liver biopsy to either find out if something new has appeared or if the disease has worsened, or if you haven't achieved the histologic goal that you think you should have achieved with a course of treatment. So I think all of those may be reasons why one does a liver biopsy. I don't think that anyone would ever mandate it for routine use, but I think people will use it as they feel necessary to better understand their patient's disease.
Thank you, David. That's very, very helpful. And I would like to follow that with another question to you again. Can we draw some parallels with the experience with pegylated interferon in hepatitis C genotype 1 treatment, where similarly there was a subset of 30 to 40% of patients who responded to treatment after 48 weeks of pegylated interferon, but others had no improvement or fibrosis was even progressing during the course of treatment, and they needed either liver biopsy or reassessment of the management plan?
Yeah, I think there are some parallels, and there are also some striking differences. I mean, one of the main differences is that we had a really good non-invasive marker of viral response, which was eradication of the virus without it ever coming back. And in those cases, when one did a liver biopsy to just sort of see what was there, in almost every case, the inflammation has subsided and the fibrosis is certainly no worse. And is often looks a little better. But there were patients who maybe partially responded or got worse. And then those patients, were sometimes rebiopsied to find out, if anything had changed or if things had gotten worse, especially if they were being considered for another, at the time, probably another line of therapy or perhaps another clinical trial. So again, it was not necessarily used in every case, but on a case-by-case basis, people might choose to do a liver biopsy to understand where the patient was after an apparently ineffective course of therapy.
Thank you, David. So I would like to turn now to the other pathologists on the panel, and this is Dr. Tim Kendall. Tim, thank you for joining. And what is the current evidence that liver histology assessment with digital pathology with artificial intelligence can predict clinical outcomes, which ultimately is what we are interested in?
This area has been supercharged by the availability of cohorts with available tissue for computational imaging, stain-free or stained, and outcome data, and then the computational tools to make the connection between features that are inapparent to us as pathologists or observers. And we had the opportunity to do this with a set of 300 in the pilot experiment with 300 cases from the Steatohepatitis cohort. So that's been set up here in Edinburgh with my friend and colleague Jonathan Fallowfield. We published in October last year, and we had stain-free imaging with the 2 photons and SHG imaging, and we're able to derive indices directly linking from some of the fibrospatial parameters that the imaging comes up with direct through to clinical outcome. We presented that at EASL last year. That was the pilot. We've got the complete work now done, which we're actually going to present in 2 weeks on Friday at the EASL meeting in Milan. And it's really the availability of these the tissue plus the rich follow-up to allow us to make direct prediction. And we now know that we can. And it's not just on our subjective assessment.
Okay. Thank you, Tim. Now, my next question is again directed to the 2 pathologists, David and Tim, and I'll ask you then in turn to comment on this. But it is well recognized that MASH is a heterogeneous disease. And the question is, will assessment of liver histology, both by conventional microscopy and by digital pathology with AI, be useful to personalize treatment for patients with MASH, given this heterogeneous background. Some analogy can be drawn, I think, with analysis of tumor biopsies for identifying subtypes of breast cancer, for example, or assessment of PD-1 expression, and then to guide the choice of checkpoint inhibitors. So what is your impression or experience, David?
I think there are several opportunities. One is the kind of work that Tim is doing now, where you might see a biopsy to begin with and find features that are likely then to respond to particular therapies. I think the analogy to breast cancer and some other oncologic therapies is interesting. There are some really exciting developments in AI just off standard histology, relating histologic features on H&E to molecular findings. And molecular analysis can often be long, several weeks of sequencing and then analysis of the data, whereas potentially AI can get you the result very quickly. And so you can predict response to particular therapies, particular biochemical or molecular events, just based off the appearance of the tissue. And it's possible, it's conceivable that once we have, say, several therapies even, that one could do a biopsy, and if they have different mechanisms of action and different responses, and you've trained your systems to recognize features that respond to different treatments, that you could use a biopsy to choose the treatment. There might be other ways to do this too, but I think it's an interesting thing to speculate about. Obviously, we're a long ways away from any technology like that.
Yeah, I mean, I'd agree. My starting point, now this may be naive, is that what we see down the microscope is telling us everything about the disease. We just have to know how to extract that information. So the way that the tissue looks is a manifestation of the proteins it's expressing, and the manifestation, therefore, of the genetic changes. And that's true in cancer, like cholangiocarcinoma. We do molecular profiling for targeted therapies. It's likely, I think anyway, to be true in MASLs as well. So with the right data sets, we would hope that we could train classifiers to predict treatment response, let's say. So talking about resmetirom, maybe we can train a classifier that will identify at the index biopsy which subset of those patients is actually going to respond, to allow it to be perhaps more targeted. I mean, we used, not from histology, but from the RNA-seq data we have, this data site, and in an unbiased way, actually low thyroid hormone receptor beta transcription network activity was predictive of a poor outcome. So, I mean, maybe we could identify histologically hypothyroid livers that might benefit and perhaps predict treatment response.
Thank you both. And I will turn my next question to Dr. Sanyal. Arun, you mentioned earlier the use of non-invasive tests. And as we know, a number of studies so far have evaluated different non-invasive tests or NITs, either imaging or serum fibrosis markers or FIB4 indices, with respect to their ability to first diagnose the severity of liver damage, MASH, or to predict the clinical outcome. Are we at a stage where a single NIT or a panel, a complex NIT, can provide sufficiently robust conclusion for the diagnosis, or for assessment of treatment response, or for prognosis? So these are three different aspects that we ask for NIT to answer.
So I think it is very important to understand that, in clinical practice, we need a certain degree of precision, but we also have to be pragmatic and not make perfect the enemy of the good. And so, we have to take into consideration the degree of certainty with which we can make certain conclusions, and also view this in the context of the risk of misclassification. So if we make a mistake in our assessment using a diagnostic test, and it applies as much to a biopsy as it does to the NITs, that if you misclassify a patient, what would be the impact on the patient? So the answer would be a little bit different for somebody with cirrhosis versus somebody with early stage fibrosis, stage 2 fibrosis, for example, because the person with stage 2 fibrosis is not at any immediate risk from a liver perspective. And even if you misclassify that person, then, you have multiple possibilities over time to, get to the truth and, figure it out. On the other hand, if you have somebody with cirrhosis and you tell somebody with cirrhosis that they do not have cirrhosis, and you don't start screening for hepatocellular carcinoma, et cetera, and the person presents with hepatocellular carcinoma or a variceal bleed, then those are pretty catastrophic consequences for that particular patient. So the answer changes as you depends on where you are in the life cycle of the patient. The second piece of this is we have to differentiate between NITs reflective of disease activity, which is telling us about the lipotoxic load to the liver and the injury, whereas markers of fibrosis. And within markers of fibrosis, we have to differentiate between markers of fibrogenesis versus static markers of fibrosis burden, because they are different biology involved in these two processes. While they're overlapping circles, they're not exactly the same. So depending on the clinical question you're asking, diagnostic, prognostic, or disease monitoring, and what you're trying to prove, the choice of NIT will depend on some of these. And certainly to get a full assessment of the disease, you need to assess what is the degree of activity and what is the fibrogenic drive, and maybe even the fibrosis load, to get a comprehensive assessment of what is happening in the liver. And to my knowledge and understanding, there is no single NIT or biomarker that really provides all of this information. So we really, in practice, when we are using NIT-based management, we look at the totality of the data, looking at different kinds of biomarkers. We are further ahead in assessment of fibrosis than we are in markers of activity, although some recent biomarkers such as the NIS2 score and the MASF score are helping us in that regard. But there are a number of biomarkers for fibrosis that also include, the ELF score, the PRO-C3s, and so on and so forth. And there are a lot of different biomarkers being studied. The FIB4 is really designed for screening general populations with low prevalence of disease, of people with significant or advanced fibrosis. And it is not a precision tool, and it should not be used for that kind of purpose. But maybe in a primary care setting, that could be the first test to figure out who should get additional testing. And then the use of elastography and circulating tests could be your next test. And then when they give discrepant results, reserve biopsy in routine clinical practice to clarify. Another thing that's very important is up to 10 to 15% of patients that we see have positive anti-nuclear antibodies. In the context of the use of Rezdiffra, there's one patient who was diagnosed with Dili type syndrome, and that patient had a lot of autoimmune features even prior to coming into the study, which of course, it's an N of one, and you don't want to overinterpret anything happening to a single case, because then you'll be accused of treating your last patient. But at the same time, when the consequence on the patient is quite severe, then I think in patients who have positive ANAs, particularly if they're high titer ANAs, it would be worthwhile to get a biopsy, in my view, to make sure if there aren't two types of pathologies in play, which a NIT will never be able to tell you. Because, if you have a ton of piecemeal necrosis, and things like that, you really need to be worried if there's something else going on, especially in the setting of a positive ANA with a titer of 1 in 320 or higher.
Thank you, Arun. That was very comprehensive and helpful, but I'd like to expand this a little bit more with another question to you. The current guidelines for management of patients with MASLD, the overall fatty liver disease, recommend performing a liver biopsy in patients where there is a discordance between the NIT results or the NITs are inconclusive. The results are inconclusive. Will this change now in clinical practice, given that there is no requirement for liver biopsy before starting Rezdiffra?
I would like to make a distinction between what is best medical practice versus the reality on the ground. And unfortunately, there is a huge gap between how people practice and how they should be practicing. Having given my soapbox comment on that, I think the AASLD guidance is absolutely on target. When there is diagnostic confusion or when the NITs are giving you widely discrepant results, the biopsy should still be used as the tiebreaker and as the reference standard to base clinical decision-making on. The idea that biopsies are extremely dangerous and also completely, non-specific and non-significant, I think is a mischaracterization. And that's probably the easiest, simplest way for me to describe it, of the truth. It is not, the truth is far from that. Biopsy gives you a lot of very useful information. And I would like to point out that for many of these NITs that are now being touted, the day-to-day variance, even with the MR-based elastography, is up to 20%, which is in the range of the variance of your observer variability in biopsy. So all the people who are promoting these things, saying that biopsies are useless, it's a little hypocritical. So we have, the truth is the truth. You have to just be evidence-based and follow the data. The science tells us that the AASLD guidance is the way to go. Whether that will translate into routine practice, the current, I think Mary Rinella had a paper showing that in 85 to 90% of patients, even prior to Rezdiffra, nobody was doing a biopsy and just making all their clinical decisions without a biopsy. And somehow I think that probably will not change, but we are hoping that with the AASLD guidance and also with some of the third-party payers, for example, the VA system insisting that a biopsy be done, there will still be a role for histology, I think, and an important role for histology to make sure the right patient gets the right drug and that we are also monitoring the patient appropriately.
Thank you. One other challenge that we likely will face in the clinical practice will be how to determine the futility of treatment with Rezdiffra. So my question to all members of the panel, and just would be interesting to hear your views, is how can the liver biopsy help in determining the futility of treatment with Rezdiffra or even other drugs that will be in future, or the drugs has either no effect or there is a need to reconsider the diagnosis for a particular patient. So maybe, David, can we start with you, please?
There are a couple of things here. I mean, one is that, I mean, people are going to default to their non-invasive tests, right? So, and probably the most basic of those. So, ALT or some easy measurement of hepatic steatosis that's non-invasive or fibrosis. If these things are unchanged, I think it's likely that the clinical team will conclude that this drug didn't work and to move on to something else. There might be, again, a situation of discordant results, though. So say, that steatosis disappears by some measure, but the ALT is unchanged or rises. So you have some discrepancy between the different non-invasive tests. Some things are indicating resolution, others are not. And again, you might do a biopsy, and I think we did see this sort of thing with Hep C, where you uncovered steatohepatitis. Patients looked like they were responding, the viral levels were going to zero, but the ALT didn't drop appropriately. and a biopsy showed a second liver disease that may not have been known before. So there's always that sort of situation that's possible. And I think, as far as the biopsy goes, that's probably where it will be used. Again, unless they move to another potentially effective therapy and there's some guideline for how you should use that other therapy, and you might do a biopsy in that situation. But I think people will default to using what non-invasive tests they're comfortable with using as a first line.
Thank you. Tim, what do you think of the role of the liver biopsy in determining the futility for for treatment in general?
Yeah, so I completely agree. I mean, the gold, let's call it the histological evidence-based gold standard would be if we had a biopsy after treatment, after a period of treatment, in clinical practice, that showed whether treatment was or wasn't changing some indices that we were able to measure. But as David said, I don't know that that's going to be ever done, really. I mean, we don't get sequential biopsies without good reason, other than in our transplant patients, for example. So it kind of goes back to one of my points earlier. Maybe with sufficient data and sufficient study of those index biopsies, maybe it's not that we use a second biopsy to histologically judge effect, but maybe all we would be able to do is to predict likelihood, and if it's Bayesian, sort of shift our probabilities as to what might constitute a reasonable treatment effect based on non-invasive tests. But there's an awful lot of guesswork in using FibroScan for the reasons Arun has said, or ALT or anything else. That it's a fuzzy mirror or fuzzy window, beg your pardon, into the liver, really.
Arun, what do you think?
So, the two things from an NIT perspective that in the clinical world are being pushed is a decrease in ALT by 17, international units or more, or a 20% decrease in ALT, and then also changes in FibroScan. And I think certainly if the liver stiffness drops by 30% or more, or the ALT drops by more than 20% or completely normalizes, if both happen, you have a greater certainty that there is histologic improvement. In this very specific setting of resmetirom, one of the best biomarkers of histologic improvement was a greater than 30% decrease in MRI PDFF. Those who had a 30% or greater decrease in MRI PDFF had many-fold higher probability. The hazard ratio, the odds of actually resolving steatohepatitis or even having fibrosis improvement compared to placebo was substantially higher in the resmetirom group. So I think those are the tools people will use. Now, having said that, sometimes you get discrepant data, and as David pointed out, you might have a patient where the PDFFs improved, but the ALT did not change, and you need to figure out why would that be? And then is there something you're missing? Is there some underlying toxicity going on? What's going on? So that would be one sort of scenario where you may need to figure out the need for a liver biopsy. The other would be where you don't meet the success criteria, but you don't clearly meet a futility criteria. Clear futility criteria is if your liver fat actually goes up and your liver stiffness goes up by more than 20 or 30%, then clearly your drug's not working. You need to move on. You don't need a biopsy to answer that question. But there are people who are going to fall in the middle, where you cannot clearly say that it worked, and you clearly cannot say it did not work. You may just be holding steady. And then the clinical question is going to be, does that mean I move to the next drug, or does that mean I stop? Or because the fact it is stable, that means I'm preventing progression and I will continue. That's a case-by-case, decision based on the totality of the clinical picture that each physician will have to make. And in that setting, I think a biopsy may give you very useful information because it will tell you, what the NITs cannot tell you, because the NITs are very clear because they're also not precision tools. So they're very clear when they're in the polar extremes, when it's clearly better or clearly worse. But when they're sort of within the range of error, of the test itself, within 10-20%, then you don't know where you are. So then, if you want to answer the question, stability versus non-stability to help you make that clinical decision to stop or continue, then I think biopsy will continue to have a role in that kind of setting. But it would be very important to get baseline biopsies. If you're going to use biopsies to evaluate what's happening, then you need the baseline biopsy. Otherwise, you don't have something to compare with. So, so you have set yourself up for failure if you don't get that upfront biopsy. If there is any possibility, you would do a biopsy somewhere down the course. And I think these are some of the thought processes that our colleagues in the VA system and others have also been thinking about, that this is not while many people are saying this is just being done to gate the number of people who will get the drug, I think there's more to it than that.
And I'm sure that the pathologists would be happier to see the baseline biopsy and the follow-up biopsy side by side and assess the changes between the two, the dynamics between the.
Well, like I said, if you intend to use biopsies to figure this type of thing out, then you need that baseline. Otherwise, you're putting the pathologist at a very big disadvantage because then they have nothing to say where the patient started from.
Thank you. So my next question is again to David and Tim. Several studies have demonstrated already the benefits of using digital pathology with AI as an aid to pathologists and in assessing the histology in MASH. How do you see, from your perspective and your experience, the increasing relevance of digital pathology in characterizing the fibrosis dynamics? Tim, maybe starting with you.
So when we get a biopsy, we get a snapshot in time, but we don't know what direction things are heading in. So are we in a phase where there is increasing fibrosis? Are we in a temporary phase when it's perhaps regressing? It's obviously a bidirectional process, and we can describe the scarring that we see. Let's just talk about scarring. And there are some features that I think we suspect can tell us which direction things are heading in, but until we have the rest of the film, we're not really going to know for sure. But what we describe is fairly blunt, fairly crude. The ordinal systems, however many scales we use, are still fairly crude. But we know there are many other features that we can derive computationally, either stain-free imaging or from matrix stains or in combination, that gives us much more nuance, much more granularity to features of the extracellular matrix. It's understanding the granularity, measuring it, that might allow us to be able to identify which direction things are heading, presence of a kind of point of irreversibility. Maybe it's cross-linking or thickness of bands that we can see, but maybe there are some other features that we can measure, and maybe understanding that might actually help define futility or what could be done for a patient. And those are the tools that we are now beginning to be able to employ on the tissue to really get that almost molecular, at least morphomolecular information.
Thank you, Tim. And David, what is your view on that?
Yeah, I would agree with Tim. The focus up to this point has been sort of to try and match what pathologist does and create a computationally based staging system that kind of puts things back in buckets. But at the same time, all of these tools that are out there, whether commercially developed or in laboratories, academic laboratories, they provide a lot more information than just that number. The very least, they provide something that's scaled, right? That's continuously variable rather than sort of integer buckets. But beyond that, they can tell you information about the character of the fibrosis or other features that I think as we use these tools more, you know, my hope has always been to be able to do this in real time, more or less, and to provide that information in a report, so that alongside the diagnosis and whatever observational information I provide, I can provide you know, quantitative information that goes beyond that says, you know, describes the character of the injury in a more detailed way. But we need to know how to interpret that information. You know, just as looking at a DNA sequence without knowing what all of those letters and numbers mean is fairly meaningless. You know, but now, after having sequenced the human genome and after having done many studies to understand how different diseases play off the genome, we can say a lot. And so I'm hoping that AI methods in pathology will provide that same kind of detail and will become routine. You know, but what we need is a lot of that sort of baseline information with clinical correlation and outcomes, so that we can build these algorithms up.
Thank you. I mean, very informative discussion, and I believe I can summarize the key takeaway from our conversation so far, that the liver biopsy remains a key diagnostic approach for the following scenarios. Firstly, to confirm MASH diagnosis when there is discrepancy in the non-invasive tests or the results are inconclusive. Secondly, to detect or exclude patients with high risk, for example, patients with compensated cirrhosis, to exclude comorbidities, like it was mentioned, possible autoimmune hepatitis, or to assess treatment response and futility of the current treatment, so that we can adjust how to proceed with patients' management plan. I'd like to move to the second part of our conversation, and this is focused on the use and the role of liver biopsies in clinical trials for drug development in MASH. And my first question here is to Dr. Sanyal. Arun, what would be the impact of Rezdiffra approval on the design of clinical trials in future?
I think the introduction of resmetirom as a conditionally approved drug is a really important milestone in the sort of history of this disease. And I have to commend and really appreciate Madrigal for taking a very thoughtful, step-by-step approach, initially focusing on really patients coming to the hepatologist to correctly identify the patients so that the right patients get the right drug. And so there will be an impact for sure. One will be in the recruitment of trials, and because if it will reduce the pool of patients that, you know, many patients, if there is an approved drug, may choose to be, receive an approved drug and not participate in a trial. Number two would be, as we think about the patient pool, there are patients who do not respond to resmetirom. So there will be a subset of patients who, having been on this drug for some period of time, will need to meet entry criteria, not that dissimilar than what we are currently already doing for people who are on GLPs. You know, increasing number of these trials have patients who have been on a GLP for 1 year, 2 years, and even if they meet the criteria for entry, then then they're allowed in. So I think that will have to be integrated into the inclusion exclusion criteria. In the results, in the long-term assessment of studies, again, depending on the type of metabolic pathways the drugs use, whether there is potential for DDIs, that will need to be considered. There is some enterohepatic circulation, so I think all of those kind of things will have to be considered in terms of safety monitoring. Probably the biggest challenge is going to be in retention. Because the regulatory official position, at least in public, has been that we have only conditionally approved this drug the current new trials do not have to use Rezdiffra as the active comparator, that the current studies need to keep going against placebo. But when you're doing these long-term outcome trials, if the liver enzyme, because patients are getting their liver enzyme checked by their primary care physician and for routine clinical use and for clinical management, and if there's any fluctuation there or something, there is always a potential for their regular clinician to tell them, or their family members or the patient themselves saying, maybe I'm just getting a placebo, why am I in this trial? There's an approved drug. I'm sitting here while my liver progresses to cirrhosis for the betterment of the human race, but I'm done, so why should I be the sacrificial goat? So why I'll just go take the approved drug. And so I think those are the kind of things that will need, that those who are going to plan trials will need to think about, and whether it is access, open label access at the end of the trial, whether there are other cutoffs, those are the kind of things to retain patients in trials that will need to be integrated. So yes, absolutely, it will have an impact, but many of these are foreseeable, and this is the time to think through those.
Thank you. So my next question is to all members of the panel, and that's related again to the clinical trials. Given that the primary endpoints for MASH trials remain unchanged, and they are focused on assessing histological changes, does the Rezdiffra approval have an impact how pharma companies and the clinical investigators together will design these trials? So specifically impact on the design, do you think there will be anything to specifically change? Perhaps let's start with Tim.
So my hope is that the trials would allow, so in their design or in the protocols or collection of data, would allow us to address the kind of more fundamental point of your question, the endpoints remain unchanged. Well, we should be able to collect data to see if we can change those endpoints. If we're just doing endpoints based on David and my subjective, with expertise and experience, but subjective assessment, ultimately we as pathologists just we don't offer a result, we offer an opinion on a stain section, which obviously has its problems. The computational pathology tools, if we can collect the data and link the two together to show that actually they are more reliable and provide more nuance, more granularity, maybe we could then move to those tools rather than our, subjective, expert-based assessments. Maybe that would improve trial design. I mean, maybe you'd need fewer participants. Maybe you'd get fewer false negatives. That's how I would like it to proceed.
David, any views on that point?
So aside from the sort of things that Tim mentioned, one thing that I think is going to pose a challenge as, potential treatments or treatments for other diseases have impact on the liver. So like the GLP-1 agonists may not be prescribed directly for the liver disease, but probably certainly have an effect on it. The potential is to kind of change the disease that we see in the liver in a way that is not necessarily predictable by the usual sorts of tests that we do. So you may end up with unusual combinations of features. Some component of the disease may be affected primarily. For example, the fat may disappear with another coincident therapy, but the other features remain, right? So I think it makes the histologic landscape more complicated the more other potential factors might be going on with the patient's therapy in other ways. And so I think that already we have challenges in recruiting for clinical trials in terms of the biopsy entry guidelines, because we draw a very tight box around the risk population for study entry. And I think that there are potential challenges to sort of hitting that target. The more other things you layer into the potential pharmacologic milieu. And so, and those things are going to have to be taken into account too with the potential AI tools that we use. And so I think there are a lot of interesting challenges ahead.
Okay, thank you, David. That's stimulating in a way. Arun, what's your take on that regarding the impact on the design and what the investigators and pharma companies will specifically need to think about in designing the future trials?
Well, I think there will still be a role for histology in the foreseeable future. It is not going to disappear. While there's going to be increasing integration of NITs into defining the study population and outcomes, but there will still be a critical role. And I think some of the very important features that will need to be identified will depend on whether you're talking about phase 2A proof or phase 2B, you know, the short-term concepts, proof of concept, proof of mechanism type studies, versus when you're doing more advanced studies. In the shorter term studies, you know, the movements may not actually be, as we've seen recently with data from efruxifermin, that if you did a biopsy at 36 weeks or 24 weeks, it's a short term. It was somewhere in that range. I'm not remembering the exact time frame, that they had a modest fibrosis improvement. But when they followed the same patients out to 96 weeks and repeated the biopsy at 96 weeks, they have 75%. That's the top line data. I'm really looking forward to seeing that data at EASL, that 75% fibrosis regression when you follow the same patients out on treatment to 96 weeks. Now we're talking serious business, you know, this is very cool. So I think having enough longevity and durability is so important. And for a while, there was a trend where people were saying, well, we'll do a biopsy at 6 months. No, why don't we do a study with a biopsy at 3 months? And, you know, I think that's a very, very dangerous path to go. We learned in the old days when we were treating transplant rejections, where the surgeons would push us to biopsy within 48 hours of giving a rejection drug, that's too soon to really see histologic clearing. In fact, some things, you know, while the inflammation comes and clears up all the dead cells, you misinterpret that there's worsening of injury. And so you have to give the drugs enough time to work. And this is a disease that goes over 20 years. You're not going to solve this by doing an early biopsy. So I think we're learning that we need to go a little longer on the biopsies. There's obviously a sweet spot because you cannot do a 3-year phase 2B trial. Those things have to be gated, which brings me to the last point, that what I would really like to see, particularly as more and more big pharma with deeper resources get into this space, they for sure should be doing spatial transcriptomics along with histology in order to get the comprehensive assessment of what is going on, to better identify responders, non-responders, predictive biomarkers, picking the right patient for their phase 3, and also being able to get better insights that for their non-responders, what would be the best partner drugs acting on which pathways and in which patients, and really help the field move towards precision medicine.
We mentioned earlier that MASH is well recognized as a heterogeneous disease, and the general belief is that combination therapies would be able to be more effective and to address the different subsets. So, Arun, what in your view is the role of liver biopsy in analyzing the treatment efficacy, the impact of individual components of a combination trials in MASH?
So if you imagine somebody with significant injury, activity, and fibrosis, the ideal candidate for combination therapy, and you treat them with a drug that affects activity and a drug that affects the fibrosis, or a combination of pleiotropic biology. So at least theoretically, you could improve everything. You could improve activity with marginal effect on fibrosis, or you could have an effect on fibrosis without necessarily affecting activity, because, you know, If you plot activity versus fibrosis, you have 4 quadrants, right? So we're taking people in the top right quadrant with high activity and fibrosis, but they could land in these 3 quadrants. Now your strategy for what you're going to do depends a lot on where you land, because if everything gets better, then it's a question of maintaining, remission. It's almost like, remission induction and remission maintenance, or whether you need consolidation therapy with more drugs for activity or more drugs for fibrosis. So until the NITs mature enough to be able to give us those type of answers, we will need to use histology along with NITs, obviously. I don't want to, because this is, being sponsored by HistoIndex, I do not want to give the impression that this is all about the biopsy, but there's a very important role for NITs. NITs are coming, don't make no mistake. But while they're maturing, there's going to be still a very important role for histology to separate out what to do with these people. And in my view, the current combination trials are all poorly designed. They're just using the same design for monotherapy and throwing it at the combination therapy, hoping something magical will happen. And I think it's a high-risk move.
Well, thank you all. We are reaching the end of the time for our webcast. And I just would like to ask the panel for any brief, short comments, concluding remarks if you had. So Tim, perhaps starting with you.
I think what's occurred to me quite a lot during this conversation is the potential massive importance where we have paired biopsies available. So maybe they're from trials, maybe they occur organically in clinical practice, but there's a tremendous amount of information we can learn comparing then and now, or over a time frame from the same patient. And so we as a community, academic or commercial, should do everything we can to maximize where we have those paired biopsies available, to kind of pool our resources. If we use them from routine clinical practice, I might have a few, David might have a few, collecting together to get a larger group to study the kinetics, treatment response, kinetics of fibrosis. That's what I've taken from this. If we have that available, we can learn a lot more about everything we've talked about.
Thank you, Tim. That's good takeaway message. And David?
So just to add something different, I think one of the things that, where there's still a use for a biopsy is where we don't understand what's going on, because the information that we're getting from other sources is not making sense, or it's changing in ways we don't understand. It does increase the complexity of what we do. It's always nice to be able to learn a disease and to study it in its purest form. But I think that those days are kind of past us for the most part. And I think as time goes by and we use more of these non-invasive techniques, it's going to call for more sophistication on the part of the pathologist, maybe with the use of other tools to help them interpret what's going on, and to pass that information on to their clinical colleagues in a way that makes it useful for them to take care of their patients. That's always the challenge in pathology, but the more information we can do without doing a biopsy, when you finally do decide to do a biopsy, the harder it is to actually interpret what's going on. So that's a challenge for pathologists as well, to recognize that and to train for it.
And Arun, any final comments from you?
Yeah, I think I'd like to reiterate that last comment that I made, and which is where I would really like to see the field move towards, is combine not only machine learned approaches to assessment of what the liver looks like under the microscope, beyond what the naked eye can observe, but combine it with molecular pathology. As a clinician, what I would like my pathologist to tell me is not only what's going on and how far along the patient has progressed, but also what are the pathways that are involved, what's driving the disease, so I can figure out what is the best molecular mechanism for that particular, especially as we move towards combination therapies. What are the best partners, that would be the best combo for that individual patient? GLPs are coming. They're not, GLPs are already here. Revise that statement. There's no question that they have had such a transformational sort of impact on the whole milieu of metabolic diseases. We already have resmetirom. So we are going to have a lot of therapeutic choices. And we hope that, unless one just is so powerful that it swamps everything else out, that there will be a need to be able to match the right patient to the right drug. So finish with, where I started, which is best medicine is when you match the right patient to the right drug.
Thank you. Before closing, I would like to thank our panel, highly informative, lively discussion. Also, I'd like to thank HistoIndex for organizing this very topical and timely webcast. Thank you.
Thank you.